Good morning, everyone. So, we are starting a session for free papers. The first presenter is Dr. Zuhaib Nadeem.
Good morning, everyone. Bismillah Rahman Rahim. Comparison quality of life and pain between fixed and mobile bearing implants in total knee arthroplasty. Myself, Dr. Suhaib, consultant from Shifa International, Islamabad. If we see in recent decades, OA has developed as a major threat to the public health in terms of advancing age of the patients and leading to alteration in musculoskeletal system. And one of the revolutionized treatment option to deal with, we have a TKA. And basically, two kind of TKAs, fixed platform TKA and mobile platform TKA. If we see from the literature, the comparison between fixed and mobile bearing have limited studies and short follow-up. In fact, it's less than 10 years. And no substantial differences in clinical results in terms of post-procedural pain, function, quality of life. And my hypothesis, mobile bearings are one of the answers to improve the functional outcome due to reduction of long-term polyethylene wear, allows increased conformity and contact area without dramatically increasing fixation stresses. It can rotate self-correction, it can rotationally self-correct, which leads to forgiving vertebral component malrotation and more tolerable femoral condylar lift-off. In inclusion criteria, we included tricompartmental stage 4 OA, and any patients which have a varus and valgus more than 25 and FFD more than 15 were excluded. It's a comparative cross-sectional studies. We included 62 patients, and we followed them at 6 months and 1 year follow-up for pain through pain VAS score and function through WOMAC score and quality of life from short form 36 forms. In our study, we had a 31 male and 31 fixed bearing platform TK and 31 mobile TK, and in our results, the VAS score is significantly improved in mobile TK as well as WOMAC function score as well. So why it's the need to think about it, if we see the progressively decreasing age of the TKA patients, and especially if we talk about the 50-year-old TKA patients, they would have an increased demand of function, increased implant loads, and definitely required a more than 30 years longevity. So we must improve polyethylene longevity as well. So mobile platform TKA group has shown improved outcomes compared to fixed platform TKA groups in terms of pain, stiffness, function, and quality of life, both at 6 and 12 months post-operatively. I know a lot of limitations we can talk about, small sample size, short-term follow-up, but the idea is the 10-year data comparing fixed and mobile bearing TK is equivalent, and patients are especially more than 65 years. These patients are low demand patients. And if we talk about the TK in patients who are less than 50 years, they would require definitely a high demand and require a function of more than 30 years. Thank you for your attention.
Thank you, Dr. Zuhaib. For the next free paper, I would like to call Dr. Sajjad Ahmed Memon.
Assalamu alaikum and very good morning to everyone. This is Dr. Sajjad Ahmed. I'm here to present a study of neglected traumatic hip dislocation that is treated with total hip arthroplasty, a journey from miserable to a happy life. The objective of study was that to evaluate the outcome of total hip arthroplasty in chronic hip dislocation by using Harris hip score system. The reason behind this objective was that the neglected hip dislocations are rare in developed countries, but it still occurs in some low resource settings. The common reasons include delayed medical care, the misdiagnosis, and the bone setter treatment. This was a retrospective study that was conducted at Dr. Ruth Campbell Civil Hospital, Karachi from August 2014 to November 2021. Total number of patients were 11, among them 10 were males and 1 was female. The mean age was 44 with a standard deviation of 8.9 years. The duration of neglected dislocation was 3 months. This slide outlines the treatment protocol according to Thompson-Esteen classification with age-specific protocols. The grade 4 with age 28 required dual mobility, total hip arthroplasty plus bone grafting. Grade 1 at the ages 34 and 51 undergoes dual mobility, total hip arthroplasty, while the grade 2 at 35 years should undergo standard total hip arthroplasty, while the grade 3 with age 38 to 49 managed with the dual mobility, total hip arthroplasty plus bone grafting. Finally, the grade 5 in older patients from 52 to 58 years of age require cage plus bone graft, cemented dual mobility cup, and the non-cemented femoral component. In short, higher the grade, older the patient, complex will be the surgery. This is the preoperative X-ray of right-sided, neglected posterior hip dislocation of 3 months old. Perioperatively, there was false acetabulum, all fibrous tissues were removed, and the true acetabulum identified under image guidance and treated with the bone graft, screws, and uncemented total hip arthroplasty. This is another X-ray of left-sided, neglected posterior hip dislocation and treated in the same manner as above, with the bone graft, screws, and the uncemented total hip arthroplasty. This is the 5-month-old right-sided neglected central hip dislocation in 52 years of aged patient that was managed according to protocol with the bone graft, anteprotrusio cage, cemented dual mobility acetabular cup, and non-cemented femoral component. The outcomes were measured by using Harris hip score system. Preoperatively, it was worse among all the patients. Postoperatively, it improves with the time. At 6 to 9 months, it was fair in 10 patients, but was poor in 1 patient. But around the follow-up at 1 to 2 years, all patients having good results with a score ranging from 80 to 89. So the conclusion of our study was that the THA is safe and very effective for neglected hip dislocation that allows pain-free mobility restoration and improved quality of life. But the very main important thing that it requires planning and the long-term follow-up. Thank you for your attention.
Thank you, Dr. Sajjad. Now, for next paper, I would like to call Dr. Hafiz.
Bismillahirrahmanirrahim. Assalamu alaikum. My topic of presentation is the functional outcome of total knee replacement with elevated BMI. The background of my presentation is the TKR is effective for advanced osteoarthritis and obesity with suspected and neglected influence outcomes. The impact of comorbidities and under investigations, the rising obesity rate, more TKR candidates with elevated BMI. The objective is to assess the functional outcome of TKR in elevated BMI patients and explore the association between the BMI, comorbidities, and the recovery. The method used are cross-section study at HMC Peshawar. 350 primary TKR patients are evaluated for more than 6 months post-op. BMI group of normal, overweight, and obese, which have further subdivisions, and the score used for was the knee society score and Oxford knee score. Comorbids among these patients were hypertension, diabetes, ischemic heart disease, and asthma. The results were the mean age of calculation was 64.3, plus minus 7.8. 68% were female. BMI distribution were 40% of normal, 44.6% overweight, and 15.4% were obese. Comorbidities were hypertension 52% of the patients, diabetic mellitus 39%, and ischemic heart disease with 14%. The asthma having 8% among those. The outcomes were the knee society score for normal there was 86.2, for overweight it was 84.5, for obese it was 81.8, the p-value was 0.04, the OKE score normal was 41.3, overweight was 39.9, for obese it was 38.2, and the p-value was 0.03. All group allowed substantial improved post-op. No significant difference was noted in satisfaction, and the p-value was 0.21. The results: overall complication rate was 12%, and no significant BMI-related difference. P was 0.18. The common issues noted were wound delay 4%, infection about 3%, and stiffness of 2%. For discussions, we have evaluated the BMI, which is slightly lower score, but meaningful improvement were noted. Hypertension and diabetes mellitus is most common comorbids, which is very common in Asian people. Satisfaction is high across the BMI groups. Challenges and outdated BMI-based surgical exclusions. The conclusion which came out was the BMI should not be the sole exclusion criteria for TKR. Pre-op optimization of the comorbidities is recommended, and functional gain substances in all BMI groups. Thank you.
So he was Dr. Hafiz. Now for next paper, Dr. Sarfaraz Baloch.
Assalamu alaikum everybody and good morning. My paper presentation is on functional outcome of total knee replacement in pre-existing complex knee deformities, our experience in Pakistan. Me, myself, Dr. Sarfaraz Ahmed. A meta-analysis of the global incidence of primary knee arthroplasty is about 203 per 10,000 cases per year, and among those primary cases, incidence of complex knee deformities is about 15% of these cases. And this epidemiological data is limited in Pakistan. Only in some northern part of the Pakistan, it's about 3.6% in rural and 3.1 to 4.6% in urban parts of the area. And complex knee deformities are those cases which includes the severe deformities, bone defects, instability, including varus, valgus, and fixed flexion deformities, which demand a knee reconstructive surgeries. Our objective of this study is to evaluate the pre and post-operative INSAL knee society score in patients with a pre-operative complex knee deformities. Materials and methods: our study was a retrospective cohort study conducted in Liaquat National Hospital and Medicare Hospital in 2014 to 21, and data was consisted of 62 patients. Pre-operatively, patients' demographic data of age, weight, BMI, comorbidities were registered in Pakistan National Joint Registry, and patients were assessed clinically, radiologically, divided into three groups on the basis of deformity. Group A with a severe valgus, varus, Group B, and C fixed flexion deformity. These are the demographic data with a mean age of 66, height of 62, weight of 78 kgs, and BMI was 32. And these are the knee society score and functional score pre-operatively and post-operatively, there was significant improvement. And these are the various implants used in the various deformities as we classified them into the different groups. Most of them are stabilized with a posterior stabilized, and more complex deformities were stabilized with a constant condylar knees, and only one fixed flexion deformity needed the rotating hinged knee. These are the knee society score over the follow-up of 5 years in all the groups, and there was a significant improvement. And these are the functional score over the follow-up of 5 years, and there's a significant improvement. This was a 75-year-old female of us with a AP, with a severe varus deformity, AP lateral skyline views, and these are the clinical pictures, which was stabilized with a posterior stabilized implant with a good alignment. In our study, we are faced with 4 complications in which, in a severe valgus knee, we faced as one transient common peroneal nerve palsy, which was improved with time, and 2 intraoperative medial epicondylar avulsion fractures due to tight structures medial and fixed with a 3.5 mm screw, and a superficial wound infection, which was managed successfully with proper dressing antibiotics. But alhamdulillah, all the complications were managed successfully without long-term sequelae. The surgical intervention of complex knee comes with a number of challenges, but we can achieve a reliable correction, good alignment outcome when performed by an experienced surgeon with meticulous soft tissue balancing and appropriate implant choice. The different implant choices, we add the posterior stabilized implants, which are a good option, but comes with a more complex deformity, we can add adjunctives, or we can go with the implants which are commonly used in the revision cases like constant condylar knee and rotating hinge knee. Our overall complication rate was lower than the most of the published complexity case series and complex knee cases, although comparison was different in follow-up duration. Our conclusion, there is significant improvements were noticed post-operatively in knee society score, functional score in all 3 groups with a probability ratio of 0.05, which was statistically significant. The limitations to our study was there was a short period of time not possible to assess the long-term performance of the processes, and no any specific criteria for the implant selection was used. In the long run, we are planning to continually follow these cases early to obtain long-term outcomes. Thank you.
Thank you, Dr. Sarfaraz. Now, for the last free paper presentation, I would like to call Dr. Nimra Rashid.
Bismillahirrahmanirrahim. I am Dr. Nimra Rashid, presenting the first case series report from South Asia on the functional outcome of stage total knee arthroplasty in patient with the septic knee arthritis and advanced knee osteoarthritis. Septic knee arthritis is a devastating joint condition that leads to the chronic pain, progressive joint destruction, and significant function decline. Approximately incidence is 10 in 100,000. We noted the rising rate of septic knee arthritis in patients with advanced knee osteoarthritis, particularly those who receive intra-articular injections. Combined septic knee arthritis with advanced knee osteoarthritis create a complex surgical dilemma for the orthopedic consultants. Sometimes standard arthrotomy may fail to relieve symptoms, and many patients persistently experience disabling pain and functional loss even after the infection eradication. Historically, the primary total knee replacement was contraindicated in septic knee arthritis due to high risk of periprosthetic joint infection. Reported rate is 3 to 36%. Even quiescent septic knee arthritis carries a 6-fold increased risk of PGI as compared to the non-infected cases. 2-stage total knee arthroplasty is a gold standard in managing PGI, consistently achieving more than 90% infection eradication. With extensive experience in performing stage total knee arthroplasty for PGI, our senior arthroplasty surgeon applied the same principle to this complex scenario. Our goal is to complete eradication of infection and restore long-term knee function. Now, we present the first South Asian case series on stage total knee arthroplasty for septic knee arthritis with advanced knee osteoarthritis, demonstrating this novel technique's successful outcome. Our aim is to evaluate the functional outcome and complication of two-stage total knee arthroplasty in patients with the septic knee arthritis with advanced knee osteoarthritis due to multiple etiologies. Our surgical strategy divided into two stages. In stage 1, we use a medial parapatellar arthrotomy approach in which we give the midline incision, total synovectomy done, multiple sample taken for the CS, primary bone cut for total knee performed, and extensive washout with a dilute iodine solution, and insertion of the antibiotic cement spacer. We give the 6 to 8 weeks of IV antibiotic as a post-op care. In second stage, we do the cemented total knee arthroplasty. Our decision based on the clinical improvement in declination in the CRP and ESR level. We remove the spacer and debridement of the cemented sclerotic bone, and finally reconstruction with the cemented constrained non-hinge implant. And we give the 8 to 12 weeks of IV antibiotic according to the culture as a post-op care. This is the retrospective case series conducted at the Department of Orthopaedic Surgery of Liaquat National Medicare General Hospital from January 2020 to January 2025, in which we include the total 20 patients, including 12 males and 8 females, with advanced knee osteoarthritis and septic knee arthritis after the clinical and radiological confirmation, who underwent two-stage total knee arthroplasty. We assess the functional outcome by the Knee Society score. Here we have a result. The preoperative knee society score, that is 45 to 52 point, which is significantly improved to 89 to 92 point at 6-month follow-up visit. Delayed second stage revision, that is more than 8 weeks, associated with a superior functional outcome as compared to the early revision. And overall complication rate is 10%, including 2 cases of superficial wound infection managed with the oral antibiotic, and we noted the 0% of recurrence of infection throughout the 5 years of follow-up time period. Here we conclude our study. The two-stage total knee arthroplasty is a novel technique by an experienced arthroplasty surgeon in managing septic knee arthritis with advanced knee osteoarthritic patients, transforming the patient quality of life without the excessive risk of PJI. Here we have some cases. Please start. Patient had ORIF due to the proximal tibia fracture, came with the infected implant, underwent the two-stage total knee arthroplasty. This is the pre and a post-operative fracture fixation radiograph, and this is the pre and a post-operative stage 1 radiograph of left-sided knee joint. We have an obvious finding of extensive bone loss with advanced knee osteoarthritis on the left knee joint. This is the final reconstruction with the LCCK implant. Here we have a case 2. In case 2, the patient came with a septic knee arthritis with advanced knee osteoarthritis, underwent two-stage total knee arthroplasty. This is the bilateral knee joint AP and lateral views with obvious finding of bilateral advanced knee osteoarthritis with extensive bone loss over the right knee joint. This is a post-operative stage 1 radiograph, and this is the final reconstruction with the right side TC3 with metaphyseal sleeve and left-sided Biomet Vanguard implant. And this is our patient functional outcome. Thank you so much.
So we'll conclude the pre-paper session here. For last concluding remarks, I would like to invite Dr. Turab. Please put a few words.
First of all, thank you to all the participants. Excellent studies. Anybody got any questions from the floor? Otherwise, I'm going to ask questions. Can I request all the participants to come to the stage, please? My first question is to Zohaib. Your data was collected prospectively or retrospectively? Well done. I think I'm proud that in Pakistan we are collecting data prospectively now as well. Well done. Yeah, well done.
Sure, sir. Our study was prospectively done at Shifa, Islamabad.
Yeah. No, I probably missed it. I just wanted to confirm. Yeah.
Thank
you. And Sajjad Haider Maiman, what was the decision to do THR and dual mobility? How did he decide which one would get THR, which would get dual mobility?
Sir, it depends upon the Thompson-Epstein classification and the age of the patient. Mostly in young patients and type 1 and 2, mostly we do the dual mobility cup. And with the grade 3 and ages around 34 and 51, we do the mostly total hip arthroplasty.
So you were worried about dislocation or?
Yes, sir.
You were worried about dislocation?
Yes, sir.
Yeah.
In young patients, functional mobility and dislocation.
Right. Thank you. And I think Arif Khan didn't present, somebody else presented. So for that study, you mentioned infection. Was it superficial or deep infection?
Sir, we have noted that a few of the patient would have like cellulitis, that's most common. We have noted in our setups. So concerning about this, if this infection is leading to some failure in obese patient, like aseptic loosening is also coming most commonly, but we are just worried about that why this is the problem with the high BMI patients. So we are conducting now this we have done this in our setup HMC. We are trying to correlate this with all the other hospitals in Peshawar as well. We are collaborating with other hospitals of Peshawar like LRH and KTH, and then it will be.
And you do submit your data to joint registry, yeah?
Sir?
You submit your data to joint registry?
Yes, sir.
Yeah, lovely.
Yes,
thank you.
Yes, thank you.
Sarfraz Baloch, how many of your patients were valgus knees, varus knees, or windswept knees? I missed it probably.
Sir, there were 22 patients in group A with valgus knees and 32 with the severe varus, and only 8 patients with a fixed flexion deformities of greater than 30 degrees.
Right, thank you. Yeah, thank you everyone. I think I don't have any questions for you. Well done everyone. Thank you.
So this session ends here. Thank you everyone. Have a nice presentations ahead. Thank you.
We'd like to thank you, the chair, for overlooking the session. Now I would like to invite Professor Amin Chonoy for the welcome note, please. Then we would like to invite Dr. Sohail Hameen for highlights of the session, please. Achha, sir.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي صدق الله العظيم. What a exciting day was yesterday. I truly enjoyed it, and I hope all of you enjoyed it. Looking forward to a very absorbing, interactive sessions to date as well. And I'm not going to talk a lot at all, so not going to, in between, not going to waste any time. So just we'll continue with this session. I hope all those who are here enjoy a lot, learn a lot, and take good messages away, good vibes away from this conference, so that when we come back in 2 years' time, we're prepared for more and better scientific content. Thank you very much.
Now I would like to invite Dr. Sohail Amin for highlights of the session.
Bismillah ar-Rahman ar-Rahim. So on behalf of the organizing committee of this second International Pakistan Arthroplasty Conference, I would like to welcome you all on the day 2. And I'm sure you have witnessed some very absorbing and very exciting sessions yesterday. And what was exciting about it was that the hall was jam-packed. And over and above that, the scientific content, I think, was very absorbing, and it actually made us pass through the day without any exhaustion and without any tiredness, actually. So I'm sure today also is going to be another exciting day, because we have really worked hard, the scientific committee, for putting up a very, very interesting program. And there are going to be sessions again on primary knees, revision knee, and there is a UK unicondylar knee symposium as well. We have some debates in between and some hot panel discussions on some controversies and some hot topics. So I, along with you all, look forward to a very exciting day, and inshallah it's going to be even better than yesterday. Thank you very much.
So now I would officially like to start the Unicompartmental Knee Arthroplasty Symposium. For that, I would like to invite Dr. Umar Butt, the chair. Co-chairing would be Dr. Athar Muniruddin, and moderator would be Dr. Mustafa Javed Bali.
Dr. Athar isn't here. Dr. Athar isn't here. Sufyan Bhai, would you like to do the honors? Join us on stage. Thank you.
Wonderful program already started, and thanks and honor to be part of this amazing educational event. So we won't waste time, and we'll start straight away. So the first talk is by Mustafa Javed, and the topic is Current Global Trend of UK National Registry Data.
Thank you very much. Thank you to Professor Shahid Noor for giving me this talk. These are my disclosures. So partial knee replacement is targeting at least one compartment, and that's usually medial, and the indication is isolated compartment, medial and lateral. Osteoarthritis with a stable knee and a low intra-articular deformity. Increasingly, we will be talking about intra-articular and extra-articular deformities, hence the reason to put that in. And the benefits seem to be that patients get up quicker, they feel that the knee is more normal, smaller incisions, and a lesser blood loss. The global trends seen are such. I think we'll get Dr. Rami to tell us about the Australian experience, and we see a linear move towards doing more of these elsewhere. But as far as the UK is concerned, and this pretty much shows my training era, when we started, smaller hospitals were doing these once or twice on their lists, and we were part of this very actively as trainees and residents. And then at some point there was a dip, and in 2018, that's when I left. Maybe they were just waiting for me to leave. But what was happening was we realized that a lot of people were doing a lot more of these in low volume centers. But
research started coming up because of the bad publicity, and there was a response back saying that yes, we had a good 10-year survival rate and we had a really good 20-year survival rate, and that's about 2018, and then slowly it started picking up for various reasons. This beauty, the cobalt chrome, highly polished mobile implant, the Oxford knee, is the most that is being used in the UK, unless I need to be corrected. And we've got so when I was around, it was about a 12% and now a 15% 10-year revision rate, but those are some things that we tell our patients even in Pakistan. And we noted from the registry that the high volume surgeons were doing better than low volume surgeons. And the Oxford bearing knee had a lower wear, but a higher risk of bearing dislocation. And I suspect Umar may tell us as to why we have fixed bearing alternatives available here in Pakistan, maybe for that reason. The Swedes are doing about 8% of these, and they have got a good survival rate. Denmark are doing more, and I suspect one of the reasons is it's being centralized to the bigger, larger centers. And Norway is a bit more conservative, and again, the trend seen is that high volume centers are performing better. So there's a trend forming, and I think that's what we will reciprocate in our practices here in Pakistan. The Australians, again, please, Prof, correct me unless otherwise. So 7%, 6-7% of these are the uni knees, 90% of them are the Oxford implant, a reasonable 10-year survival rate, and the revision rates, again, are higher in low volume centers. We've got a limited data, and all what we've got at institutional reports, and that really depends on procurement availability of the implants per se, and people comfortable enough to be doing those. We do have limited training here. I mean, I work in a center where we get mostly complications and tertiary level complex problems. I don't necessarily see intra-articular arthritis. I do see more extra-articular deformities, and in our practice, at least in my practice, we're looking at joint preservation mechanisms and management plans. Again, we do a lot more of the knees, total knees as opposed to uni knees here. We've got dips. We had a recent dip where we didn't have enough stock for uni knees, and I think it's come back again. And the cost constraints instruments remain, and I think it's the long-term cost in instruments. In terms of that 15% revision rate, and for them to convert to a total knee replacement, and most surgeons would prefer to get on and do a total knee. Recent systematic review, fantastic in terms of the fact that there is very low perioperative morbidity. Yes, there are high revision rates, but we do tell them, but the time that they have that knee inside, their patient satisfaction is really good. And they've got similar pain relief as compared to total knees in selected patients. And again, the same thing, high volume centers, higher improved UK outcomes. So I'd say it's underutilized as far as we're concerned in Pakistan. The revision risk is high, and the message would be that this needs to be centralized. We need more registry data, and I think as more joints come in, we'd be slotting them in. It's been a while since I've done them, so I'd need retraining for these uni knees again, and I think that would be not an unreasonable option. So I thank you for that.
Thank you very much, Dr. Javed, for putting some realistic facts about the registry and the data which needs to be there. So it is said that for a surgical technique, you need an expert to actually be there to actually tell you how to do it. And for the surgical techniques, I would like to invite Dr. Umar Bhatt to actually show us step-by-step surgical techniques for fixed bearing uni-compartment total knee arthroplasty.
Thank you, Sufyan. Okay, so my name is Umar Bhatt. I'm the orthopedic surgeon here in Pakistan. These are my disclosures. Currently, I'm the president of Pakistan Hip and Knee Society, and rest of it you guys can see. So what is the setup? Obviously, a lot of you who are already doing arthroplasty know that the uni knee is quite similar to arthroplasty. If you're doing Oxford, you do hanging position. If you're doing a fixed bearing, you can do in a normal standard total knee arthroplasty setup. The only difference I would say with Zook or whatever fixed bearing is that on the left side, if you're a right-handed guy, try to bring the patient almost down to the table end so it's easier for you to access the joint, because uni knee, the access is small and it's sometimes very difficult to look at the alignment of the prosthesis, especially when you're doing the tibial cut. So the setup I do is spinal anesthesia. I always give my patient intra-articular injection of local anesthesia and adrenaline almost 20 minutes before the surgery starts. Tranexamic acid 1 gram at the beginning, post-op, and 1 gram post-op again, so 3 grams almost. Adductor canal block, local infiltration. I don't use tourniquet anymore, and I only use it during cementation. So that's the setup. Interestingly, we just had the implant last week and I performed the first one. So that's the uni patient, typical 56 years of age. Medial compartment, mark the knee as you see on the joint line. Inject local infiltration with some adrenaline. Allow it to work, make an incision onto the medial side, no more than 4 centimeters, sorry. Do the medial parapatellar approach, open up the joint and you'll be able to see clearly bone-on-bone arthritis. But that's not enough. You have to see the lateral compartment properly. Evert the patella, look at the patella. If there is a bit of a lesion, it's not a problem. Remove the osteophytes from the femur to have better access of the sizing. Also remove some osteophyte from the notch area. This is a fixed bearing, so you apply the size of the cutting jig will give you 3 to 4 millimeter. You do first the first cut, which is the straight cut, and once you do this cut, the most important thing is to leave this saw. I like to leave it there. The only reason it protects my bone and doesn't let me go to the medial lateral compartment. Making sure that the Homan is not put too much deep, but in this position, and then you can do the remaining cut of the tibia. You can see the wear is mostly central. Once you remove the bone piece, you can see that, and then you use the spoon, which is 6 to 7 millimeter. It should go very easily with the finger without any struggle, and then you can do the extension block, and then always measure the extension block with the alignment rod. Once you have done that, obviously you can do the distal femur cut, and that should be no more than few millimeter according to each individual jigs. As you can see, it's a very small slither of bone you take from the distal femur. It's a resurfacing procedure. It's not a knee arthroplasty. You look at the balance. You go straight to the femoral component. Make your cut on the femur. Apply the jig more on the lateral side rather than on the medial side, because the femoral component should be more toward the lateral side, like I'm demonstrating in here. Once it's fixed, you can do the remaining cut, which is the chamfer cut and the femur, posterior femoral cut. As you can see, also very small thin bone. Once it's done, remove the meniscus. That's the good time to remove the meniscus, as you can see. And you can then do the tibial measurement, which has got a special jig in this fixed device. Apply the tibial base plate, put the pin, and then do the drill, and then do the checking of the trial. Once it's done, 1 millimeter spoon should go easily. And then you can do your cementation of the tibia and on the femur, put the trial finally, and then wait for the cement to settle. It's always nice when you're doing tibial component to externally rotate the foot at 90 degrees. It exposes the tibia much easier, because with a small incision, sometimes very difficult to see the tibia. I always apply cement only on the middle and anterior part, not too much on the posterior part. And this procedure is complete. You put local infiltration in the knee joint, and that's the whole part of the procedure. Finally, the fixed bearing is applied, and you can compress it with this device. Take the knee through range of motion, look at the balance, the alignment is all good, and that's compression is done. This was around, I think, 7 millimeter poly. Procedure is complete. The size of the incision, as per measurement, is no more than 4 inches. So that's the post-op instruction of mine. Mobilize ASAP, physio home. On the same day they can go. I have a physio lab machine which I apply on all my patients to allow early mobilization. and they can go home on the same day. So I would like to invite all of you for our next year meeting. I hope you guys can join us. The theme for the next year meeting which we are running is Reimagining the Joint. Thank you very much.
Thank you, Umar. I'd like to invite Darren. Prof will talk about his tips and tricks of a successful uni knee and how to avoid pitfalls. Thank you.
Thank you, Mr. Chairman. It's again a great pleasure to be here. And really, it's been a wonderful day yesterday to be able to rekindle old relationships with friends from Singapore who have previously journeyed to Singapore, and to make many new ones that I hope we can continue this friendship for many years to come. And I also like to thank Dr. Umar for his excellent display of that surgery. It was extremely slick, and it really covers quite a lot of my points that I'll be sharing as well. So I've been asked to talk about partial knee replacement tips and tricks for success. Okay, good. So as you've heard, there are certainly many pros that this procedure can offer to our young arthritics, to patients who have isolated component disease. We've heard that it provides a less invasive procedure with much faster recovery, a higher return to sports, and lower risk of certain complications such as bleeding, pain, and length of stay. Unfortunately, it also comes at a price, and what detracts it from being the perfect solution is that we've seen that there are higher reoperation and revision rates reported. And principally, the ones that we really want to avoid is that of aseptic loosening of our components and progression of osteoarthritis. And this is actually quite technique specific. So I would say that the uni or the partial knee replacement is a technically demanding procedure. I would say that also it's a bit more demanding than that of a total knee replacement. And as a result of that, surgical volume matters. And we've seen in the literature the impact of surgical volume and usage has on the survivorship. And out of Oxford, this excellent paper talked about 10-year survivorship of a cemented mobile bearing partial knee replacement. And in surgeons with a low caseload and a low adoption of this procedure, they had a survivorship of 83%. And when you are a high caseload of more than 10 cases per year and high usage where you're doing over 20% of your knees with a partial, then you have a survivorship of 90%. So you can see that surgical volume does matter and does translate to better survivorship. And in order for us to be excellent surgeons for this procedure, we perhaps need to adopt a different mindset, or the right mindset, in such that we offer UKA, or we consider UKA as the default option for every patient that walks into our clinic. Because if we don't consider that an option and we default to total knee, then our volumes will always be very low. Additionally, what is supportive in the literature is that indications have become less restrictive over time. So now we're dealing with heavier patients, patients with greater deformity, and yet having good clinical outcomes and survivorship. So we've heard about the tiny, minimally invasive exposures that Dr. Umar has performed to install his joint replacement. And I would say that in the pursuit of having a really sexy, tiny incision, we should always never go so far to the extreme that it compromises our implant position. So we should have a fairly generous incision to a point where we are able to get the job done well. We shouldn't perhaps maybe aim to get the incision down to maybe like what you see on your left, which is about 4 centimeters, but have a exposure that exposes at least 1 or 2 centimeters of the tibia and extend superiorly to perhaps maybe the upper pole of the patella, but if possible, avoid violating the quads or the VMO. We can move the knee into different positions to get access to different parts of the knee, excise off the fat pad, which will further our exposure. And finally, in some tight cases, we can actually do a medial patellar facetectomy to further improve our exposure. Component position is paramount. It's the most important to survivorship. And I would say that the tibia is the easiest component to get it wrong. So spend most of your time getting that part right. You want to minimize bone resection, preserve the joint line, and finally, with whatever hooks or the paddles or even robotic assistance, try to put in the largest appropriate tibial tray so that it rests on the posterior and medial cortex in order for us to avoid subsidence. As we've also seen in the previous video of having a loose flexion gap where you were putting the spacer in and only having very mild or at least only finger tightness, all right, we want to aim to have a loose flexion gap. All right, the extension gap can be stable, but the flexion gap should never be tight. And we can achieve this through both manual instruments or robotic assisted. So for manual, we can use the paddles or the spacers, and we just hold them with just 2 fingers and run them in and out of the joint, and it should not bind that spacer. In terms of robotic assistance, which we will see a bit more later on, we can manipulate the position of the components in terms of posterior tibial slope or anteriorization of the femur to open up that flexion gap. What we want to avoid is having that rocking horse effect, where when the patient goes into deep flexion, there's a lot of pressure on the posterior aspect of the tibial tray, and it causes liftoff and loosening of the implant. In terms of posterior tibial slope, you really try to replicate the tibial slope with your resection. In this image, you can see that once we've removed the tibial biscuit, we can look at the lateral side, and we have equal amounts of bone cut both anteriorly and posteriorly, indicating that we've sort of restored the posterior tibial slope with our implant. However, many times in our clinics, we will see patients with extremely high posterior tibial slopes. And so a word of caution if we are still trying to chase that extremely high posterior tibial slope. Me personally, I don't replicate all patients' posterior tibial slope, especially the ones with very high angles, because of the risk of possible subsidence and ACL rupture. In such cases, I would max out my tibial slope to about 8 to 10 degrees, and then if the flexion gap is still tight, I would resect off more posterior femoral condyle. Interprosthetic alignment is important because we're dealing with very small implants and we want to have central loading of the partial knee replacement in extension. If we, as we heard, we want to lateralize the femoral component, sometimes all the way into the notch, because if we don't and we medialize our femoral component, we will end up having that femoral component edge loading on the medial tibial edge when the patient goes into extension. And this is a result of the screw home mechanism, which we must appreciate, where the tibia goes into external rotation when the knee goes into extension. And this is sometimes difficult to appreciate because we do the L cut of our tibia in flexion. So what we want to do is aim using the lateral edge of the medial femoral condyle as a guide. We want to aim for a neutral or slight internal rotation. And as you can see on the robotic assisted image, we lateralize the femoral component and we are able to centrally load that onto the tibial tray. Finally, there are 2 ways of fixing our implants onto bone. For the mobile bearing, they have a cementless option. That option is not readily available for fixed bearing, and so I would say that the gold standard is still cement fixation for our fixed bearing components, and is a critical step for survivorship. And this is something that you should not rush. In total knee replacement, you have much more surface area, and you can be a bit quicker in terms of cementing, but for partial knees, you really have to spend a bit more time and be a bit more meticulous. You have to make sure the bone is dry, fill the lug holes and keels with cement, apply cement to both the bony and implant surfaces when the cement is not too viscous. And then finally, when I insert the components in, I will further compress it by putting a small 1 to 2 millimeters spacer to further compress the cement. And I would allow the cement to cure at 45 degrees. And finally, I would actually allow the cement to cure with a trial insert in place, so I can remove it and subsequently clear the back of cement. Because some cement will invariably extrude out from the back, and you don't want to leave cement out at the back, which sometimes can fragment off and create a loose body. So in conclusion, UKA survivorship, I believe, is very sensitive to technique, and hopefully with these simple tips that I have shown, we can improve our outcomes and provide patients a durable, less invasive option. Thank you very much.
Excellent talk, Darren. Well, amazing tips and tricks. The next speaker is Rami Sorial for My Journey of Unicompartmental Knee Replacement Arthroplasty, 25-year experience.
Thanks very much, Uma, Mustafa. Great presentations this morning. I'm going to talk to you a little bit about mobile bearing, my journey over the last 25 years. You had a couple of presentations on the fixed bearing, so we just look at the alternative. The Australian Joint Registry, it is about 8 to 10%. 50% is the Oxford now, the other 50% is fixed bearing, with the restorers going with the Mako being the main one. Okay. Does that not work? Okay, we got a problem with the type. Okay, this is what I want. So at the end of the day, you're going to make a decision to go ahead with the unicompartmental knee arthroplasty, and this is what you're looking for. A good range of motion, full extension, full flexion, patient is very happy. But the question is UKA versus TKA, and the discussion continues. It is a global important topic. Can you tell which side had the total knee replacement, which side had the uni knee replacement? Any takers? TKA on the left, UKA on the right.
Sorry.
The message there is if you do a good job, whether it's UKA or TKA, you'll get a good result in the same patient. So, design of the Oxford goes back to Goodfellow 1976, basically spherical femoral component, tibia was flat, a mobile bearing, highly congruent on the articular side, flat on a polished chrome cobalt metal base plate. And this articulation with the Oxford hasn't changed over decades. It's probably the only unicompartmental knee arthroplasty that's available now that follows the same design principles as when it was first born. Phase 1, 1982, one size fits all. This was through a standard medial parapatellar approach. Phase 2 in 1987, they introduced the bone mill for more accurate balance, reduced the dislocation rate, again through an open medial parapatellar approach. The designer series were excellent, 98% survivorship at 10 years, a lot of enthusiasm for using UKA. In 1996, the minimal invasive surgical approach was introduced, and phase 3 instrumentation came in 1998. I started my journey in 1999. Thank you. 1,000 cases from Panda were reported, 96% survivorship at 10 years, all looked very rosy. I started doing UKAs with the Oxford 1999 and continue to do the Oxford to date. Now, why are we not progressing? Okay, thanks. Swedish Arthroplasty Registry, however, tells a different story. And that is there are mixed results. When you look at registry figures, they certainly don't produce design surgeon publications. They don't produce high volume surgeon publications, as was implied in previous presentations. 10% failure rate at 6 years, data obtained 13 to 19 centres. What it meant is the introduction of courses to teach people how to put in UKAs made a big difference. In 2004, the cementless design was introduced. It was limited introduction to Europe and Australia. Good early results. I'd been cementing between 1999 till 2004. In 2004, I commenced cementless Oxfords and continued to do it 2 decades later. And that's what I use exclusively. With the introduction of cementless, the femoral design just had an extra peg added to it, but the basic design philosophy remained the same. The microplasty instrumentation was subsequently introduced, and that's what I use today. My knee practice at the moment, somewhere between realistically 15 to 25%, it varies year on year as to how many I use, but as is well published, if you do 20 to 22 unis in a year, you'll get good results. You do less than that number, you potentially have worse results. The clinical scenario is in this patient, I'm very selective in who I choose to do a uni on. Patient has to have medial compartment pain, monocompartment arthritis, a varus thrust as you can see here. It needs to be correctable deformity, and the patient needs to point to the medial aspect of the knee joint as to the location of their pain. If they're pointing over the anterior or lateral aspects of their knee joint, I don't do a UKA. Dick Scott's publication, 1989, Identified a lot of contraindications. This is controversial and, as a lot of you would know, has been outdated. The Oxford group did 1,000 consecutive UKAs with no contraindications and found good results. So as a consequence, things like age, weight, labour, activity level have all been scrubbed out, and so the unicompartmental knee arthroplasty can be utilised in a wider population. For me, however, I still remain selective. This patient in my practice gets a TKA, despite BMI not being a factor in outcomes and results. And what I use is the Oxford support. If they can't fit on the support, they don't get a UKA. Correctable deformity, either clinically or using a valgus stress manoeuvre. I do use MRI on a quite regular basis to identify the lateral compartment and the ACL. I went through a phase of 5 years using the signature patient-specific instrumentation with MRI on everybody. It allowed you to assess the size, the balance, the position. It produced patient-specific instruments, particularly on the femoral side, that were quite good, excellent fit, and that applied. So you went femur first for the first time. And then on the tibia, it was a little bit clunky. If you had good geography as far as osteophytes were concerned, it was an excellent fit. If you had atrophic changes, it was a poor fit. When the microplasty instruments were introduced, they were an excellent adaptation, and I continue to use that now on a regular basis. Remember, it's anteromedial osteoarthritis. This is the pattern of deformity you want to find, and the posterior aspect of your resected biscuit needs to have normal chondral surface with full thickness. My patient setup is using the Oxford support, leg over the side of the table. I do use a tourniquet. Oxford, mark the anatomy, MIS approach, iodine, IABAN, and this is how we get started. So this typical incision, as Darren and others have already identified, it's the MIS approach. Go through, find the VMO, that's the top mark of your incision for the arthrotomy. Make a straight arthrotomy, and then I do a mini mid-vastus in order to allow that retinaculum to be reflected, and that gives you excellent exposure. Use your Z retractors effectively in order to be able to protect your medial collateral ligament in particular, and to identify the anterior cruciate ligament is intact. Remember, this is a bony procedure. Never release ligaments. Ligaments balance is achieved by removing bone appropriately for flexion extension balance. Look for the ACL. If it's not intact, open the tray for the TKA. Now, more recent evidence has shown that if you've got a clinically stable patient, you go in, find the ACL is not intact, you can still go ahead successfully do an Oxford knee. I don't do that personally, but I accept the evidence that's out there by the Oxford group. Check the lateral femoral condyle, check the trochlea, check the patella, make sure chondral surfaces are okay, you're doing the right operation for the right patient. Flexion has to have normal cartilage. The way you size the femur is using a spoon. The spoon goes to the posterior aspect of the condyle, pull forward, make sure there's a space. I use the gillies in order to, this is a small, extra small spoon. This is sitting on the bone, it's too small. The small allows me to get a gillies in there, it's about 3 millimeters. That's the right size. Then we open the appropriate instruments for this patient. We apply the spoon, connect that through the extramedullary guide to the tibia using a G-clamp. I use a size 4 as a minimum, and that means we'll be using a size 4 polyethylene mobile bearing. This is the cutting block that's adjusted. It sits against the anterior aspect of the tibia. It is pinned in place. You can use 1 or 2 pins, depending on the size of the patient. 1 pin is usually enough. Then you direct your reciprocating saw between the medial femoral condyle, posterior cruciate ligament. Try to internally rotate it slightly, make your cut. When you make your cut, make a parallel cut. Don't lift your hand, don't drop your hand. What you don't want to do is over-resect the posterior cortex. That sets you up for potential fracture. So make an equal cut all the way down onto the cutting block, and then use the sagittal saw to take your biscuit out. Once you take your biscuit out, the correct thickness, it confirms anteromedial osteoarthritis, intact posterior condylar surface. That is a good resection for the appropriate indication. Trial your base plate, don't overhang, make sure it's sitting pretty, particularly anterior to posterior. Drill your medullary canal, put your medullary